This is the Emergency Medical Minute, sponsored by Health One.
So, quick medical minute relating to the recent update of ATLS and one small aspect of it. So, when ATLS talks about treatment of traumatic tension pneumothorax and, the initial treatment of it, whether it's in the hospital or when we first kind of think someone has a pneumothorax here, a lot of times we talk about a needle thoracostomy or a needle decompression. And the classic teaching was in the second space and the midclavicular line, so kind of the anterior chest. And, it's always been a little bit of a, challenge potentially to feel the ribs in this area, kind of know where you are, avoid things like the heart or great vessels. And then there's been other issues that a couple studies have looked at. And the main issue or the main issues are that the needles a lot of times actually don't get into the pleural cavity, into the chest in this space. You think that there's a decent amount of chest muscle here in some people. The catheters that we sometimes use are small and flimsy. Even a 14 gauge IV catheter, once you take the needle out, the catheter is pretty soft. And if you've got a lot of muscle there and someone's moving around, even if you do get in, a lot of times the catheter can kink or get dislodged. And over the past couple of years, there's been a couple of studies, some looking at the anatomy of people. They'll take, just people who are getting chest CTs and they measure the chest wall at that area and compare it to the length of the catheters. And a lot of these studies found that in most people, the regular, even like the longer IV catheters that we would use don't get into the chest in that space. And then they've looked at, when they actually, people have had these and a lot of times they're not effective. So the trend has been towards recommending if you're going to do a needle thoracostomy, doing it in the area where you usually put in a chest tube. Even if you just feel your chest wall, anteriorly here compared to the lateral fourth or fifth intercostal space, it's a lot thinner of a chest wall over on the side there. You can feel the anatomy a lot better. It's a lot easier to get the needle in there. So that's kind of the general trend. And now ATLS, which is kind of the standard recommendations, is leaning towards that lateral fourth, fifth intercostal space where you're going to do a needle. And then besides needle decompression, there's also this idea of a finger thoracostomy, which you might kind of hear someone say, we're just going to do a finger thoracostomy. And that the idea is that you do the first couple steps of a chest tube where you make the incision, open up the chest cavity, and then just put your finger in to decompress the pneumothorax. And then if someone's really sick, and let's say it's just middle of the night and there's only one provider here, you might just move on without putting the chest tube in, kind of come back to that, put the chest tube in later. But once you get your finger in, you've decompressed the chest, released that tension pneumothorax. If there's a lot of blood, you'll know it, and you can put in a chest tube if there's a lot of blood. But that's another kind of thing besides putting in a chest tube or putting in a needle that's not going to work. So, any questions? Thanks, guys.
We are on a quest to provide the world with free medical education. Please help us out by rating us on iTunes, following us on social media, and subscribing to our newsletter at emergencymedicalminute.com.